It's a great pleasure for me to introduce our first keynote speaker, Monika Fuehrer. She is a pediatric oncologist and a palliative care physician, the head of the Pediatric Palliative Care Center in Munich, which has a really impressive inpatient ward, but also a very extensive outpatient activity and home care facilities and services. And one of the really focus of the research work of Monika is advanced care planning, and she will share some of this with us. So thank you very much, Monika, for accepting our invitation, and the floor is yours.
Thank you very much, Katrin, for the invitation, and I'm very happy to see that so many colleagues are in the room, and I want to start and share what we did in research and in practice with advanced care planning. So I will start with my slides. I hope you can see them.
Yes.
Okay, thank you very much. So I start with Cicely Saunders because she said, listen to your patients. They are telling you what they need and who they are. And I think this is where we start from when we think about advanced care planning. And advanced care planning comes from the adult medicine because it enables patients with decisional capacity to identify their values, to reflect about their meanings and consequences of illness scenarios, to define their goals and preferences for future medical treatment. And also that helps them to discuss these with family and healthcare providers. This is the definition in Lancet Oncology by Retiens et al. We have to think about how this applies to pediatrics and to pediatric oncology. And we thought, why is this relevant? Could this be relevant when we started our research? And first of all, parents are not always available in a medical crisis. So, and there's a need for planning ahead. But the most important thing is that it's very difficult to raise end of life or life issues or the question of life prolonging measures in acute crisis situations. So parents and also the patients themselves want to be prepared. But until today, the discussions on parents' or patients' wishes are often only brought up in the situation of acute deterioration. So ACP aims to facilitate shared decision-making and also aims to avoid hospital and especially intensive care admissions that are no longer in accordance with the wishes of patients and parents. What are the peculiarities in pediatrics? Even in pediatric oncology, we see complex medical conditions with long variable trajectories. And sometimes the prognosis are still uncertain. And also with patients and also with the healthcare providers, there's a high emotional impact of end-of-life discussions for children. Many of our children do not have decision-making capacity themselves, and that's why often parents have to decide, and we focused in our research on the parental side of ACP. And there's still uncertain legal status in Germany, and I think also in other countries about advanced directives in pediatrics. Therefore, we need adjustments to the adult concept of ACP, and we need to know, well, what are the needs and the challenges of pediatric ACP, and we try to find these out involving patients, parents, and healthcare providers. We asked the healthcare professionals and also the parents what are the needs and what do they fear when they engage in pediatric advanced care planning. And here's the first quote of a mother who said, these conversations are also very difficult. But in the end, I have realized that this has been effective. not to avoid this, but to repeatedly work a little in this direction, but then you need really sensitive people. So what we found were three main topics, and I want to focus on these in both the healthcare professionals and the parents. This was timing, communication, and decision-making, and documentation. And for the timing, you all know that there are parents that are not ready. They have fear of giving up. They wish to keep a kind of normality and focus on the present, and they wish also to maintain hope. And there are some wrong time points in parents told us. This is immediately after the diagnosis. I think this is clear to us, but also close to an acute crisis or under time pressure. Parents feel ready when they're aware of the child's severe condition, when they recognize the futility of life-prolonging medical interventions, and when their perception is that there's a decline in the child's quality of life. So, in terms of communication, the parents and the ACPs, they share many of the topics. All of them prefer to have early discussions, and the parents want the HCPs to proactively offer ACP. They also want to have open and honest information, and they want to be prepared of what may come. Parents also need, and this we should know, they need time to reflect and to cope between the discussions. And both sides want to involve the child in an age-appropriate way. Their schedules follow-up discussions that are needed. And this we included in our model. So when it comes to decision-making, parents want to focus on their child's personality and also what supports the quality of life of the child. They want to discuss their fears, and they want to be prepared. And also, it's not that they make their decisions during the discussions often, but they need to discuss important issues as a couple and also with family, friends, or other stakeholders. So we need to give them time in between the discussions. This is very important. They don't want to be urged then. Especially they don't want to be urged by the ACPs to decide. They want to digest the information and allow the decision to evolve. And this was a very important point. They want the discussions to be open to all outcomes and non-judgmental. When it comes to documentation of parents' or patients' wishes, parents often told us that they are reluctant in some kind to make decisions in advance, and especially to write them down and to sign them. Some of them prefer to decide in the situation, and they are afraid of being bound to the advance directive. On the other side, the HCPs want to have kind of legal certainty, but some of them are also feel discomfort with the parental advance directives. They are afraid that signing their AD might be a burden for parents, and they also are aware that parents can revoke their decisions in advance. In conclusion, both sides want to start as early as possible, but both sides are also aware that this should be a stepwise process that allows to make the journey together with the parents and the patient. Both sides also wish, especially the parents, to have written information, not only about medical, but also of psychosocial end-of-life issues. And in some cases, it's also important to have roundtables with all care providers. And both sides, parents and the HCPs that might be confronted with an AD, wished to have a continuity physicians a physician that knows the patient well and is available in acute crisis situation. This also can be a team. It should not only be, or it cannot only be a person, but it could also be a team that knows the patient very well. The advancce directives are much more needed by the healthcare providers. And I think we should be aware that advanced care planning and also the directives should be implemented in the healthcare network. So all HCPs involved should know how to deal with these documents. Therefore, we need some guidelines and also professional education. I'm sorry, I have a little sore throat. So we then started to identify key elements for pediatric advanced care planning together with parents, healthcare providers, and stakeholders. And I want to show you our programs that involved of this process. And this is a stepwise program where we started with the preparation of the process and the introduction and the framing of what advanced care planning means, to introduce it and to frame it with the family. And this means that we need to know the family in front. So it doesn't make sense to start with advanced care planning as a physician that doesn't know the family. We really need a trusting relationship in advance. And also we need to assess whether parents and patients are ready already. We work as with two facilitators, and those two come from two different professions. Most of the time it's a psychologist or a social worker and the physician that knows the family best. We try to gather information about the care network, and then we start to offer the family PACP. The first module, we introduce to the family and the patient what does PACP mean. And we also try to clarify what the parents expect to talk about and what the professionals expect. And then we can set priorities and plan the main discussions together with the family. And also very important is that at that point, we try to discuss the participation of the child or the adolescent. And we accept both that they want to be part of, especially the adolescents, part of the discussion, or they want to have separate interactions with the team. Then we start the main discussion process, and parents are often surprised that we start talking about the child. We don't start with the emergency scenarios or disease-specific scenarios, but we always start with discussions about the child. And we not always talk about end-of-life care issues and what they wish, because this sometimes is too early for parents, so it might come at a second or third step. So what do we mean when we say we focus on the child? We ask the parents, what kind of person is the child? What are the hopes, wishes, fears you have for your child? How do you perceive the condition of your child? And very important, what does quality of life mean to your child and to your family in everyday life? So this is sometimes the most important part, and especially for the parents. The parents, but also want to go to emergency situations, and they really want to know emergency scenarios and what they can then do, how they can act. They want to have a treatment plan, and they also want to go through disease-specific situations. They want to know what perhaps what decisions may come to them, what are the treatment option plan, and they also want to talk often about a palliative care plan. Not all patients want to engage in discussions about death and bereavement and the place of death. This sometimes comes in a second or third step. But this is not the end of ACP and the process, because we then validate what we've heard and we try to document the process. And then, very important, we implement what the patients and the parents have decided together with the team. And this means that we recapitulate and validate the decisions and the documentation. We identify care network work partners that should be involved and informed, and we determine how often and when we want to re-evaluate the PACP. Then we or the parents inform the care network partners in personal conversations. And at that time, we can also address potential conflicts with perhaps other persons in the care network. So what you can see is this is meant as an iterative process. So we can start with the first cycle, perhaps without talking about end of life wishes, and a second and a third cycle. Parents and also patients told us that this was very important, that they know they can get back to the ACP process, and they can also revise their decisions. In conclusion, in our research, we found that PACP should start early, but as a stepwise process. We already had this. I'm sorry. What we find, and this is what we have as results in our pilot study, was that parents and also professionals found it very important and helpful that we work as a multi-professional tandem, because parents found that their different needs are addressed, and that we write conversation protocols after every session. So this allows the parents to feel listened and understood. We also share these protocols, and the professionals are ensured that they have understood everything right. The flexibility was very important. So the number of the discussions and also the duration of the process is flexible and was individually adjusted. And in our team, we repeat the discussions every 12 to 18 months to ensure that the decisions are still valuable. So when we asked the parents what was helpful, they told us that the module focusing on the child was very important, and they were surprised that we in the beginning focus on this topic. And one mother said, what I most remember and found most exciting was that it wasn't just a standard process of going through emergency scenarios, but we were given time to talk about our child. Who is he? How is he doing? What are his strengths and weaknesses? That was handled very well. And also they told us that it was very important to going through these future emergency scenarios. And this was also a quote of a mother. We talked about different emergency scenarios and what to do in which case. That was important for me, and to know what can possibly happen and what I can do. And also valued that documents and the wishes that were documented. For the professionals, it was important the content of the program. And this was perceived as very helpful, and the modular approach that helps to structure the process and to have some flexibility. And this is a quote of a colleague, and he told us that he said, I prepared the ACP discussions along the modules. I found it helpful as an orientation and how to structure the process, but I discovered pretty soon that I have to adapt it to the needs of the families and adjust it depending on the development of the process. And this is one of the outcomes. We used the decisional conflict scale to see whether there was a significant difference before and after the process. And in all parents, we saw that they felt significantly more certain about their wishes and their decisions. They felt better informed. Their values were, they could also talk about their values and get it clear. They felt very well supported. And this was not significant, but also there was a difference in the effectiveness of the decisions after the process. In summary, there are some pros and cons of the program. The acceptance and the satisfaction was high, and most of the processes were completed, and there was a high number of finalized PSCP documents. However, and this is on the side of the healthcare professionals, this was very time-consuming, and some of the processes took a long time to complete. The professionals and also the families perceived the program as helpful to structure it, the process, and also it was helpful that because of the modular program, it was easy to adapt it to the needs of the family. The families felt understood and prepared. I think this was also due to the that we always made the notes of every conversation. And they also felt that their values and wishes are represented in the documents. So our most important outcome was that the parents' decisional confidence increased strongly, and we didn't see any increase in depression and anxiety during the process in the parents. So you can, yes, we have to ask ourselves, where are the adolescents and the children? And we did not do research on this topic so far, or did not complete the research so far in our own group. But I think all of you know the Voicing My Choices. And Lori Wiener recently published a paper where they did a new and actualization of the program. And here are the key sentences of the Voicing My Choices program, and that is broadly used to engage adolescents in ACP processes. And this is how I want to be comforted, how I would like to be supported. So I do not feel alone. This is new. And there's also who I want to make my medical care decisions if I cannot make them on my own. Then also the type of life support I want and what type I do not want. And what I would like my family and friends to know about me. This is, I think, comparable to Focus of the Child module in our program. And also my spiritual thoughts and wishes and how I wish to be remembered. And there's a recent paper of the group of Mary Lyon. This is from 2025, where they addressed the pediatric advanced care planning and the adolescents' preparedness and quality of life in an RCT. And what I found a little bit surprising was that there was an increase in anxiety, depression, and pain after 12 months in those that had the advanced care planning discussions, but not at 3 and 6 months. And so far, I do not really understand where the problems were after 12 months. So I thank you for your attention, and those that supported our research, and especially my research group, Anna Mons, Katrin Knochelberger-Gatzweiler, Kerstin Hein, and especially Domenico Borasio. And I want to end with Snoopy. Someday we will all die, he says. And then true, but on all the other days we will not. And this is one of the focuses of our RCP discussions, is all the days when we will not. So thank you very much. And